computer, so just remember that.
So Physio Network do a whole bunch of different masterclasses, and I've just started this one by I guess like pain physio. This, like today's PD will just cover module 1. There's 4 altogether, but they're pretty interesting. Partly because I probably don't agree with everything he says, but I think that makes it all the more interesting. But this first module was just really good, talking about communication, and made me think about a few things that I thought we could discuss. So I guess, yeah, the overall course is called No Pain, a Practical Guide to Persistent Pain Therapy. Today we're going to talk about module 1, which is the language of pain, recognizing communication barriers. Learning objectives were to explore different types of pain narratives, consider communication do's and don'ts in clinical practice, and reflect upon verbal and non-verbal communication barriers. All right, so it's not all about the nail. So I'm going to watch this video first, and then we're going to have a think about these things here. Let me just pause sharing for a second. You guys see a YouTube video now?
Yeah, that transitioned well. Cool.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. You do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on.
Ow.
If you would just
Don't.
try to see things my way.
All right. What do we think about that video? Even before you look at any of this, just like, what do we think? Let's start with eyes, because he seemed to really enjoy it.
On mute. Yeah, that was awesome. It's just so typical a presentation of people when coming in, and if we're too pain focused or too too focused on one thing, we can sometimes not be there for what the client really needs from us. And it's amazing. Some people just want to be listened to, reaffirmed, and shown that we care. I absolutely love it. It's not about the nail. Did you also share once a nail story about someone who only got pain, I believe, when they had a nail through their foot? Jack, you said that they had a nail through their foot and they thought it went through the foot, but it didn't, or something.
Might have been me or just I can't remember. Yeah. But yeah, I know the story with the bloke.
It was in one of the videos I showed in the last.
Yeah. So just so relevant. But yeah, no, I just think like you said, that communication style around these things is so important, which I love to hear, which I really loved hearing about.
Rose, what did you think?
It was a great way of like showing it, because I don't know, I'm not really like aware with this concept kind of like what's behind the pain. It's not really about the pain. I don't know, it's confusing, like, but it like spelled it out really clearly.
Yeah. And Jack, what do you reckon?
Yeah, I think it was good. I think it's it's a good one for physios, because like that I'm sure you'll probably maybe go into it, that nail is a bit of a metaphor for our biases of what we sort of think people might need when we should be listening, and sort of the patient is in that position of power, and we should be determining their treatment mostly on what they want and need, rather than jumping to okay, you need exercise because I like exercise.
Yeah, definitely. I mean, I've got it here, like, if we consider the ladies' like perspective, sorry, Alfie's going crazy right now. For the lady, the nail is like a metaphor. You know, that's why it's not about the nail, it's like representative of how she's feeling, and like that pressure. Whereas like for the guy, he's like, well, of course you feel pressure, like you've literally got a nail in your forehead. But like, so to him it's very obvious, like just get rid of it and then it'll all be fine. But for her, it's not about that, and it's not that obvious. And I think understanding, yeah, that we don't see things or feel things the same way is really important when we are dealing with our clients, just like Jack said. All right. Yeah, so as clinicians, do we want to choose what is best, tell our patients what is happening, what to do, and what exercise are needed, or do we think there's a better approach? Hint, no, we don't just want to tell them. We're not here to just instruct. I feel like our role is more to support and guide rather than just dictate. So yeah, that video can be a really good way to, I guess, be aware of two different types of thinking. And then we can bring it back to like our biopsychosocial approach. So even if everyone could just go through and just quickly say what they think biopsychosocial means to them. We'll start with Jack.
Biopsychosocial, I guess, for me means in terms of, I guess, treating a patient, sort of just considering what structures might be involved or causing their pain, how one's, I guess, and social environment might be causing or contributing to their pain, and also considering how they feel, believe, and think is, I guess, their belief systems around treatment and pain is affecting their pain, or yeah.
Rose, what do you think when you see the word like biopsychosocial?
I don't know. I haven't really come across it that much. So
if you broke, I guess, like the different parts of it, like bio, psych, and then social, what do you think that could tell you?
Just like how they like all interact, how like the psychological side interacts with like the environment around you, then interacts with like what's going on, like in terms of like the physiology, I guess. Is that right?
Yeah, definitely. Riley, what about you?
Yeah, same as Rose. I literally don't think I've ever heard that in my life, maybe once. But yeah, just seeing how all the different aspects kind of interact and affect people.
Do you have anything to add?
Yeah, look, I just like what Jack said, but also like the idea of sort of zooming in, zooming out. And for me, biopsychosocial is really just taking a step back and looking at all the different factors that are contributing to the person that's in front of you, and acknowledging all those things. And it's why I'm such a big believer in not recipe treating or treating everyone exactly the same. Because when you zoom out, you can look at everything that's contributing to who's in front of you, and it makes definitely makes a big difference to their method of care. So yeah, zooming out is the other thing I'll add to it.
Definitely. So yeah, coming back to the video, Riley, I'll send it to you later. It's just like a minute long, pretty funny video, but it may be physical, like, you know, we and the guy in the video can see the nail, but for the person in pain, it can actually be hard to express exactly how they're feeling, and more importantly, what they're feeling. And so by not just focusing on the nail in her head and listening to what she's saying about, you know, it's really hard, feeling like a lot of pressure, et cetera, like you saw how her response to him changed when he just said, you know, I understand that must be really hard. rather than just trying to fix her problem. Want to help someone, shut up and listen. Words of wisdom. So he then talked through the 1, 2, 3 of facilitation. So again, coming back to that concept of, as clinicians, we're guiding our patients rather than just telling them what to do. So step 1, we want to listen, obviously. Then as we're listening, we want to find out what people want. And then most importantly, we want to help them find what they need. And I thought that last one was quite interesting, and I bolded it to remember myself to talk about it. But for me, help them find what they need, I think, is a really good way to kind of summarize it, because even if, you know, we take a simple example, like person A and person B come in with, you know, a grade 2 ankle sprain, you're not necessarily going to manage those in the exact same way, and what they need from you might not be the same. So I think that concept of, you know, supporting them and guiding them to find what they need, and then again helping them and supporting them to get there. Like, you're not going to fix their problem, you're just going to be the support to guide them through that process. What do you guys think about that?
Yeah, I think it's sort of like understanding what we can do and understanding our role. You know, like for an ankle sprain, yeah, we know we're the best practitioner profession to help them, but for another different condition or pain, we might not be the number one best profession to take care of them. So just, I guess, understanding our role and our boundaries.
Mm-hmm. Even if, I guess, we take a little like step back, and this doesn't just have to apply to times you might have seen a physio. If you think about any kind of health practitioner that you've seen, I'm sure most of us probably would have had an experience where you've had, say, maybe like a doctor who just tells you what's going on and tells you what to do, and you have no say in the matter, versus a practitioner who kind of informs you of what they think's going on, explains, you know, how you're presenting, and then gives you options, and kind of facilitates that decision-making process with you. I know personally, I feel a lot more empowered by that second situation. Does anyone else, like, has anyone had that experience, I guess?
I just feel so much more empowered when I feel like I'm part of the decision-making process. I think that started for me when I hurt my back initially, and probably, as I always said, I've had some, I think, undiagnosed stress fractures in my back because I never had the MRI to confirm it. But just being part of the process, even as a teenager, I think was very important. And the physio actually empowering me to make the right decisions about exercise and what I need to do to get better. I think that was really cool. So yeah, not telling, but guiding. I do really like that concept.
Yeah.
I think it makes people feel more comfortable as well, and like it helps them understand more if they're a part of it, if that makes sense.
Yeah, I agree.
I feel like,
I mean, even
sorry, Jacinta, when like
No,
a practitioner comes in, when a practitioner like comes in with like, this is the answer, like it kind of just makes you feel like they're biased, and then it kind of like, personally, I would be more likely to go get a second opinion if they didn't present to me all the options. And like, a second opinion's always good, but like as a practitioner, if you can say like, this is what it could, other options could be, like just that trust, I suppose. Yeah.
I mean, even like, I'm very stubborn and I don't like being told what to do, but if someone, you know, said like, here's my opinion, this is why I think that, here are, you know, some options based on what you said you want to achieve, here's how we're going to get you there together, I would be a lot more likely to actually comply, rather than if someone just said like, you've done this, you need to do this to get better. I'd be like, okay, I'm not going to do that.
Yeah.
All right. this one's a bit of a bigger slide. So basically, people that are living in pain, we could say it's maybe easy to think about how to express their pain experience, pain most specifically, pain is sore, ouch. But if we look under the surface, of what else is going on, coming back to that biopsychosocial approach, we might see distress, isolation, worry, uncertainty, expectation, confusion, apprehension, chaos, depression, anger, fear, frustration, just to name a few. Like, that list is never ending. And if we think about even exchanging the word pain for the word distress, I guess we take almost like I've said before, that zoom out, we take a broader look at them as a whole, and we can more thoroughly look at, I guess, like their complex needs, and then have a better idea of our role as clinicians. So he said here, pain may be too simplistic of a word, whereas distress can give a more holistic, patient-centered view. I agree in part with that, but I think to take that even a step further, we've talked about before in some of our communication shoots, we don't start the consult by saying, how is your knee pain, or what's sore today, why are you here? We kind of say, how you going, have a conversation, what's brought you in today, and we really zoom out even more to capture more information about them as a person. I guess probably more the physios, but girls, feel free to chime in as well. Do you have any thoughts on that concept? Jack or Ives?
Oh, sorry, I thought you were asking the girls.
No.
Yeah.
I love following up, like the next sessions, asking them how are they moving, or how are they how are the exercises going, rather than how's your shoulder pain going, because you're already from there, you're starting to focus on movement or something positive rather than looking at the pain.
I just think the biggest thing is to shift away from the pain talk, which is just too easy to do, because it's usually why people come in. But when you shift away from those things and focus on movement, and it's amazing how pain tends to improve at some point as a result of focusing on the big things. Like, and I can think of a lovely breakaways client I'm seeing right now who came in with some neck and shoulder and was pretty focused on it. And I was just more focused on her neck and her shoulder mobility and movement. And lo and behold, 3 sessions in, her pain's remarkably better. So I love that. Pain may be too simplistic a word. Absolutely. Remember what pain is. Pain is just so interesting and complex. There's so many reasons for it. So I think as physios, if we can put it into context and also not be deterred if they're still in pain, because like you said, our goal is to try and help them achieve their goals and get them back to baseline. Sometimes you have to go through a bit of pain to do that. So not to be afraid of the pain. Our job is not to band-aid pain, that's for sure.
Yeah, and that's why I said, like, I agree with that second dot point, like distress, might be a better term. I agree with that to a point, but I still think just focusing on more like, negative perceptions can still be maybe not so helpful. Like, personally, when people come back in, I just say, like, how's the body feeling? Because then you might get, like, even a patient today, like, we're treating her neck and her shoulder, but she was like, that's feeling like all right, in terms of like pain, but just generally I'm feeling achy because I did a big weekend of gardening. Okay, so you're able to do gardening, you haven't been able to do that yet. Like the neck and shoulder, which is what I've been treating, tolerated that well. Oh yeah, cool. Whereas if I just said, how's your shoulder pain, we might not have gotten that extra information and insight. Yeah, I think sometimes disagreeing with some of this stuff, or like challenging it, is actually more interesting to us. Girls, do you have any thing to add with that slide?
No, all good.
Good.
I agree. I feel like distress has negative connotations. Yeah.
Yeah.
But I do agree that pain is, I agree with what you say.
All right. So then he went to talk on about different types of narratives. So this study, like, it's pretty old, but still broke things down into 3 types of narrative. So if we start with restitution, yesterday I was healthy, today I'm sick, but tomorrow I'll be healthy again. It's more of a Western medicine, I guess, view on things, you know, really focused on medical science. That's going to get me better. I believe that I can get better. Although people with persistent, you know, or chronic pain do not necessarily fit into this narrative. Then we come down to chaos. The most frequently, I guess, like unheard or uncommon. Feeling like there's no one in control. So I can't control my pain. My physio can't control my pain. My doctor can't control my pain. No one can. The challenging of listening is to refrain from steering the teller, so the patient, away from the difficulty of telling. That's when we just want to come back to listening. So step one of, I guess, that 3 steps to facilitation, and often disjointed and without sequence, which kind of makes sense if we're thinking chaos. Then we've got quest, which faces suffering head on. There's a belief that something is to be gained from the illness experience. We believe that there can be change, and quest stories search for alternative ways of being well. So before we even go to the stuff on the right, what do you guys think about those 3 narratives in terms of, I guess, like, you know, maybe in the context of different types of patients that we see? Do you think most could fit into one of those 3 narratives?
Yeah, I think so. I think, you know, the majority are sort of that restitution, and do believe in, you know, they come into physio because they think it's going to help them. You know, if you find someone in that chaos, which is, I guess, rare, that sort of comes in and, you know, doesn't believe that what coming to physio is going to help them, it's kind of like, well, what are you doing here then? I think if you can, listening is obviously the key, but I think in that scenario, I would try and get some humor and get some smiles happening after listening. But yeah, it's that would be probably the most challenging one.
Ives, what do you think?
Yeah, isn't it nice when you treat people in the quest phase though? I mean, and we do have some people like that who are just very face suffering head on. That sounds a bit dramatic, but just that belief, I like that belief that something is to be gained from the illness or experience, or they just want to change and they want to work well. I think it's so lovely when you see those people, and we're trying to attract more of them, which is good. But also I think it's worthwhile mentioning people can go from the chaos to the restitution to the quest phase as well. You know, with really good effective communication and how we work with them. And it's why I have that big belief in seeing people more often early, because we can help empower them go through those stages, and long term they have great results. So just something to keep in mind. We don't see too many chaoses these days, which is nice, but they do come in, but it's an opportunity to help them, you know, through the phase. But yeah, restitution people are also great, you know, to have, because they have that belief.
Yeah, there's context with all of that. So he was saying commonly, you know, if we are going to put it in an order, we might see that they start with restitution and then say it continues to persist. We might see chaos where they're just getting a bit frustrated and then eventually come to quest. But like, there's no correct order. There's not like just one thing that we see. Everyone is different. And he also made an interesting point, this quest narrative, you know, overall, like we would expect, you know, it's a positive and helpful thing for most people, but it could be, I guess, so intense to the point where it's unhelpful. So if you consider someone that is so fixated on the pain or their symptoms, they're desperate to find a cure. The example he gave was like, you know, they're seeing physio, the chiro, and the osteo all in one day. That also does fit into that quest narrative. So again, it's just, I guess, applying a grain of salt to each of these, you know, different narratives that we can look at. But I thought that was interesting. Girls, do you have anything to add with that?
Yeah, I was actually going to say the quest thing may not always be good, because sometimes people are so fixated on getting better that when it doesn't happen as quick as they believe it should, then it can be like a bit crushing for them.
Yeah, even like that bottom bit there, you know, quest or search for alternative ways of being well.
Yeah, and they're like so fixated on getting better that like they're not really willing to do something that will benefit them in the long, like for a long period of time. Like they just kind of want it fixed like that.
Hmm.
But yeah.
Jacinta, did you say this doesn't relate to chronic pain?
No, it does. I think,
Okay.
you know, like it's quite an old study, but I guess the concept can be interesting to consider different narratives that our patients might present with. I would say,
Yeah.
you know, I don't have that much experience with this, but, you know, it says here, people with persistent pain don't necessarily fit into this restitution story. You would probably, based on my limited understanding, expect to see more in this kind of chaos phase if they're early on and it's uncontrolled. But
Yeah, because I'm just comparing it to my dad has like chronic Achilles problems. And like I reckon he switches between all 3 phases, like all the time.
yeah, I reckon it's an ongoing cycle. And you
Yeah,
can,
like it's ongoing.
you know, it's not linear.
Yeah, that's how
It's
it's kind of
certainly
looking
not
at it.
linear. Yeah, and I love the phrase Venn diagrams. There's people would be elements of all, you know, it's which is interesting, and that's what the challenge is when we see people in clinic, for sure.
Absolutely. All right, so we're going to do a bit of a reflective exercise. So there's a few statements coming up on the next slide. For each of them, we'll just take a couple minutes. I want you to think about if you agree with each statement, if you recognize your own clinical reasoning with any of the statements. Girls, you can just kind of refer to what you've seen in sessions with us, and I guess like related to your own experience. And then what do you notice about the language being used? So do you agree? Do you recognize, I guess, some of yourself in these statements? And then what do you notice about the language? So have a read through those. We'll just give it a couple minutes. Do we need a little bit more time or are we done?
Good.
Good. All right. Do we agree with any of those statements?
Some more than others.
Not linearly, that's for sure.
Are there any that you do agree with?
Well, I mean, number one, I don't agree with. Number 2 and 3, I agree with more, but it's not like 100%.
Hmm.
You know, number 2 is it's a good bias to have. Exercise or movement is, you know, one of the big ones for low back pain.
Do you think that's a bias, saying that exercise is a good bias?
I think it's probably one of the better biases to have.
That's your bias.
My bias.
I agree. I'm just saying.
Yeah. You know, well, I agree with it.
So that second question, do you see any part of your own clinical reasoning or clinical skills in any of those statements?
I don't think about it too hard. It's just part of parcels of the package. A little bit, I don't know, can be. I mean, you don't want to complicate low back pain. You don't want to complicate this statement, but you can't be thinking like that sort of thing at the same time.
Yeah. What about you, Ives?
Damn it, Jack. That was pretty spot on. Don't agree with one at all, of course. I don't have to. Yeah, that just doesn't sit well with me at all. I do understand what they're trying to say by giving too much choice, and people do like direction, but yeah, just maybe 10% or something. And with the other two, yeah, look, I definitely feel a bit more with 3 than 2. But at the same time, yeah, with 2, there have been sometimes times I haven't given very much, and when someone comes in with pain and you understand that there's so much going on in their life, of having a conversation is so important. So yeah, just like a bit like what Jack said, feel a bit more towards 2 and 3. Probably for me personally, 3's probably the most important, the one I resonate with the most. But they're very interesting statements, I have to say.
Yeah, I think the same as both of you. 1 is a bit for me, but even like if I look at 2, yeah, I would pretty much give all of the exercise, but not necessarily only exercise. I think that's an important distinction to make. And then with 3 as well, yeah, I think the objective assessment can play a big role in choice of exercises, but then I tend to work out what is best. I would say that really should be done in consultation with the patient. Like that's a collaborative process.
Feels so subjective it's just as important with exercise as well.
Yeah, exactly. You need to look at that whole assessment process. Girls, what do you think about those statements?
Do you do this kind of stuff at uni? Like during your physio course or the clinical reasoning?
Kind of.
Kind of.
No,
I mean, I'd
not
be
at all.
interested to know what you think, like forget trying to almost think like a physio, like literally just based on your life experience so far from like doing sports science, doing some interning, just life in general. I'd be interested to see what you think about those statements.
I agree with everything that you guys said, but I don't like number 1. I don't agree with it, but being someone that does love structure, I kind of do like it. Like to an extent. Like if they didn't ask me what I want to do. If I wasn't in like, yeah, like, I don't know how to say it. Like
what if your physiotherapist gave you a bunch of options? You said, I understand all of those, but I don't feel comfortable making the choice. I trust your best judgment.
Yeah, that would be better than just saying, here's this and this, go off and do it. Like that I wouldn't like. But I also wouldn't like to make choices because I wouldn't feel like I would like make the right, like, I don't know, I'd just be second guessing it the whole time.
Yeah.
Just seems very nice. You ever get the, I don't know if this situation's ever come up where you go, look, this is what I think you've got. This is the best treatment for it. What do you think? Or like, this is what I think you should do. What do you think? And they just go,
I don't know.
You're the physio.
Yeah.
Tell me.
Absolutely.
But I'm just trying to be good.
I'm just trying to subtly get you involved in the way I want you to think.
I was like, aren't you the expert?
And yeah, I get that look all the time. But the great thing is that the majority of our ideal clients appreciate feel like they're empowered to be involved in that process. But I get that all the time. You're the expert. What do you think? I'm like, I understand that.
I think with those people, the way that you frame that kind of conversation is most important. But yeah, some people are just difficult. Point blank.
100%.
Yeah, no, I definitely agree with Rot. Like I agree from a physio perspective, you'd be like, no, number 1. But from a patient perspective, you'd be like, well, you're the physio. Yeah. I don't know.
That's where I'm a bit torn.
No,
so
exactly.
Like it's very interesting. And I've definitely been sat in front of like some people and they've like asked my opinion and I'm like, I don't know. Yeah, it's interesting.
Definitely. Right.
Yeah.
So We don't learn from experience, we learn from reflecting on our experience. There's supposed to be another word in there. We don't learn from experience, we learn from reflecting on our experience. What do you guys think about that statement? Let's start with Ives.
We don't learn from experience, but from reflecting on experience. Yeah, I love it. It's a big positive. I always tell you guys, you know, it's okay to fail, it's okay to make mistakes, but we have to learn from it. So you have to reflect upon the learnings. And in the journal, what I used to do, which I don't really do anymore, you know, I'd always really write it down and highlight it, and when I'd make mistakes, in my opinion, and try and remind myself about it and make the most of it. And I highly suggest doing it, because it's through the reflection you won't make that mistake again, and we're going to continuously make it because we're human. That's totally cool. So definitely, I challenge you when these things happen to lean into it, to learn from it, because otherwise it's an opportunity completely wasted.
Yeah, I love it. Riley, what do you reckon?
Yeah, everything I've said I agree with. Yeah, I don't know what else to say. Like, it's just I just agree with it. And reflecting on it, like, you might not even think you're reflecting on it, but if you're learning from it, you obviously have reflected on what you did. Like, even if it's subconsciously. So I think, yeah, it's good.
Rose?
It's kind of conflicting in my head, because the fact that you reflect, like, you can't really have an experience without reflecting on it, if that makes sense.
Sure.
Because yeah, like, of course, yeah, I don't know. Yeah, I agree with the statement, but I don't think it would have been an experience unless you reflected on it. Otherwise it'd just be like a moment in time.
That's a good point.
But yeah, I don't know.
Jack, what do you reckon?
Yeah, no, I agree. Just because you have experience in doing something a number of times doesn't make you an expert or better than someone with little experience if you're not doing anything from that experience. If that makes sense. Or applying what you learnt. I figure that is what reflecting is.
Yeah. Rose's comment has really got me spiraling in a good way. But I guess what I was thinking before, when I was writing this up, was maybe, for me at least, the most easy example to think about is two clinicians that are 20 years out. One of them stays up to date with new research, is even though they know that they're really experienced, they still recognize that they have flaws, and they're constantly reflecting on what they've done well, what they could do better, how they can grow, etc. And then the other clinician who just thinks, I graduated, I got the degree, that's what I learned 20 years ago, that's what I'm going to do every day till the day I die. And having those as the two examples, I know which physio I would rather see. And in that, I guess in that context, saying that experiences in 20 years of being a physio doesn't necessarily teach you anything unless you're reflecting on it during that time. Does that make sense?
Yeah.
Oh, that's so well put. I mean, I used to work for a practitioner who was out 25 years, and I wouldn't respectfully send anyone to her. She's a lovely person, but she treats very differently, and she hasn't kept up to date. She clearly hasn't reflected upon her clinical load, and that is the epitome of what you just spoke about, Jacinta. That's not what physio is, because she's not reflecting and getting better and improving. And that's a great thing about having a team like you guys. You're always going to challenge all of us to keep doing that, and what is the best way to learn and go forward. I think that's really exciting. But you have to, I was really into what Rose just said. You wouldn't believe, Rose, people just experiencing and not thinking about it. I think it happens more commonly than you think.
That just shows that you're a wholesome person, that you can't not reflect on anything.
Yeah, it says a lot about you as a person.
I'm so confused by what I said.
I think I'm going to spend this
Got it
afternoon
recorded anyway.
Yeah, classic Rose.
Literally.
philosophical spiral. It's fun.
But it was great philosophical, man. I love this stuff. This is just so me as a physio. It's good to talk about. Love it.
Love this whole course by this guy.
Yeah, I need to do it myself as well. I will. It's awesome.
All right. So this is kind of just building on that, but I thought this was interesting. So as clinicians, we gradually develop a variety of technical skills to add to our toolkit. But without good communication skills, all the other things we use don't work as well. Communication and education are the keys to unlocking the other tools in your box. So if you have really good hands-on skills, but you can't hold a conversation or explain what you're doing, are your manual therapy skills that good?
No.
Absolutely not. Sorry for my bias.
I just think this, without good communication skills, all the other things we use don't work as well. I think that's a really interesting concept.
And to Riley and Rose, remember I was talking about students, we're talking about the interview process and academia. Like, if the reason why I really have a lot of respect for universities that go through interview processes is because you can be academically very smart and very gifted, but if you can't communicate effectively, you're not going to be a good practitioner, whether you're in private practice, the hospital system, whatever you're doing. And it's the same thing here. If we can't communicate effectively with our clients, we're never going to be able to be effective practitioners, because it's such an important part of what we do. So a little bit of our bias here, but I think it's very important to really start to understand how it fits into everything. And also, I think, as Jacinta and Jack will probably tell you in their journey, and sorry to talk for them, I hate doing it, but you know, when you're still building up your toolkit, if you can get really good at this stuff, your toolkit will just come in and make you better and better, and it helps you build rapport and work with your clients. Jacinta or Jack, do you have any thoughts about that, just as new grad physios?
Yeah, I think just the focus or your goal has to be to focus on improving communication over the other. Well, learn what you can at uni on the other two, but uni you're not going to get taught on your communication. But I think as soon as you leave uni, that's got to be the focus, because if you can't, it doesn't matter what you know, because how are you going to convey that? How are they going to listen to you or connect with you? Yeah.
I think I also found it reassuring as a new grad to know that, things that I lack, like maybe, expertise or like hands-on skills or like just knowledge in general, as long as I can come back to the fact that I can communicate well, then I'm already doing a good job to start with. Like some complex patients I had early in the year, just having, building that rapport and then having the confidence to say, like, I'm not 100% sure what's going on, but this is what I think we should do about it today. And this is how we're gonna, I guess, like work through this together. I think if I didn't have those communication skills, it would have been a much less positive experience for myself and the patient. So yeah, that kind of helped me a bit. Oh, I'm just going to plug my laptop in. Girls, what do you think about, especially, I guess, that middle one, without good communication skills, all the other things we use don't work as well?
Yeah, I agree with that. It's so important to have good communication. Otherwise, like, that's half the job, is having good communication, because then you can create like rapport and make people feel more comfortable, which is sometimes half the issue, is that they're a bit like just unsure and a bit uneasy. So yeah, I think that helps with that.
Yeah, I agree as well. It was so interesting that one of the interview questions was like, why is communication important in physio, and how does your communication change between different people? And like I could feel this is what they were like trying to fish out of me. And yeah, like I pretty much repeated what we're saying now, which is good. But I use the example of like having like a PT in front of you versus having like someone who's never been to physio. Like just the way you'd change your communication and like how you like adapt your communication skills to like different people. I think that's pretty important too. Because like the PT is going to want to hear like he might want to hear like more in depth, whereas like the other person's probably going to forget if you tell them that.
Yeah.
So yeah, no, is it like they obviously place value on this as well, which is good.
Absolutely. Right, so finishing with a few just little, this is just for us to chat about and discuss our thoughts. So this is a study, again, pretty old, but still interesting, I think, looking at communication do's and don'ts. So seeing communication as the most vital skill in your toolkit, setting the tone to join with your patient, develop a shared understanding through formal and informal chat, use playback for confirmation, so like clarifying information, follow their lead, be flexible, prompt sensitive information, show empathy and acceptance, versus don't provide opportunities for misinterpretations of ambiguous information. We'll come back to that. To come to the pressure of a structural diagnosis, ask yes or no questions only. Jump in during the first 2 minutes. We'll come back to that too. Miss opportunities to capture issues that require perceptual change. Challenge the patient, be judgmental, or go it alone. So before we kind of go into these things on the right that I pulled out, what do you all think about these do's and don'ts? Does anything jump out to you?
They're pretty good, aren't they?
For 2005 as well.
Yeah, that's a long time ago. That's
Comes
nice.
the pressure of a structural diagnosis.
That was the one that jumped out at me. Yeah, love that. 100%.
Pity it's probably still not.
Jack's dealing with the situation right now about that. Crazy, but absolutely. And even in our management plans, which we're looking at re-changing, it's a provisional diagnosis to give someone understanding, but not a pressure of it's definitely this. A great story was Stephen May, who plays for the Melbourne Demons, who just won in the grand final. He hurt his hamstring the week before, or 2 weeks before, because they had the bye in between. And the doctors decided not to tell him the extent of injury and how bad the scan was, even though they did it. Can you believe this? He had a 6 centimeter tear in his hamstring, so a high grade 2. And they said, we're just not going to tell him, and we're just going to do rehab based on his symptoms. So he genuinely didn't know the extent of damage in his hamstring.
Yeah, I saw, it was, I guess, like a physio or some health professional, I guess, like dissecting that and saying like in what kind of situations you might make that choice versus not. I thought it was super interesting.
Yeah, so interesting. And he played well. But he didn't let that succumb him from playing. And you're not going to do that all the time, of course, but for a grand final, kudos to the support team and what they did. That was incredible.
Absolutely.
Elite sport's another level.
That was
yeah.
So, yeah, it really is. It's insanity.
So I guess a few things I picked out. So tell me a story. How can I help? That's a nice, open, just tell me everything that's going on. I thought this try to stay quiet for 2 minutes thing was interesting. I definitely understand the concept of wanting to, let them just have the, have the stage and tell their thing. But I think it comes back to, nothing's ever textbook and not every patient's going to be the same. Some patients, you say what's brought you in today and they give you a 15-minute rundown of their entire life and, why they're there, and you don't really have to do much. But other people do require a lot of prompting to kind of get information. So I think try to stay quiet for 2 minutes is probably needs to be taken with a grain of salt. What do you guys think about that concept? Stay quiet for the first 2 minutes.
I think 2 minutes can be a very long time.
Yeah.
I think just let them speak until they're done and do what, like kind of what Meekland spoke about last week, where you just pause for like 3 seconds once they're finished. I think that might be a bit better.
Yeah.
Like you read my mind, Riley.
Yeah.
Stop it.
Yeah, I've been trying that lately, and
Mm.
it's definitely it's definitely worked. Like you get another sentence or two out of the patient.
Just try your best not to interrupt, because it's in our nature to want to interrupt, and it's amazing what comes out. So yeah, the concept's there. I think the timing's a little bit long, but yeah, something to keep in mind.
Rose, do you have anything to add?
Yeah, I think it should be focused on interrupting more so than time.
Yeah, I agree. I thought the other one that jumped out to me was this, don't provide opportunities for misinterpretation of ambiguous information. So I think they worded that a bit over the top, but essentially considering, like, not leaving open the opportunity for them to misinterpret something that you've said. And we know from the communication shoots that we've done in the past that that's likely to happen anyways. But if we can make every effort to make sure that we're being as clear as possible and not leaving things open to interpretation. And for me, the easiest way to think about that was, not everyone is coming into this session with the same knowledge that I have. So I need to consider what I know based on just generally being into health and fitness anyways, plus doing, 5 years at uni studying this kind of stuff versus what they might know as a 40-year-old who, has never really been into fitness and works in finance. I can't presume that they're going to have the same background, context, and understanding of things as I do. Let's start with Ives. What do you think about that, I guess, concept, misinterpretation of ambiguous information?
Oh yeah, I mean, absolutely. It just.
I'm gonna take off now, guys.
Yep. Right. Cool. See you, Jack. I just so agree with it. Remember the comment I said that in a consult that 70, what was it? They'll forget 75% of what you say, and then half of what's left over they'll misinterpret. So you're best off being very clear about the 2 or 3 key things you want to get across with that. And that's where you don't want to be ambiguous in your diagnosis and stuff like that.
Absolutely.
Yeah.
What do you think, girls? Because I think this is where having you two in the sessions is going to be super helpful. Obviously, you've got like a pretty good understanding, but it's still different to what we've done, like having done the physio degree. I think you guys will be a nice like middle ground for now, and could potentially, for lack of a better word, help to call us out if maybe we're going a bit too like into it and not explaining things. What do you think about that?
I think there's like 2 ends of the spectrum with you guys as well. There's like either you, how do I want to word this? So either you're too grey in what you're saying, and therefore they take parts out of context because it's all too grey for them, or on the other end of the spectrum, you're saying like this is exactly what it is. So I think like there's a really fine line in like providing like the right information, and I think particularly like misinterpreting as ambiguous information. Like if you ask a lot of people like what did the physio say, a lot of the time they don't even know what, like if they don't have any experience, like they don't even really know like what the physio has said a lot of the time. Like my friend has a really bad ankle at the moment, and like she can't even tell me what's going on. So yeah, it is tricky though.
I think it's a very case for case thing. Like, yeah, like I don't know how to say it, but obviously some people you can be a bit more like on one end of the spectrum than the other, like what Rose was saying before. Like if you know they have like a good understanding of, you know, the body and stuff like that, then there is room to be a bit more like specific in what you say. But then on the other end, you don't want to be too, for people that don't have that awareness, you don't want to be too like vague that they think like, what did they just tell me? Like, if that makes sense.
Yeah, definitely. I think as well, it's important, like I've even been trying more recently to be conscious of, even if I'm just saying something like, you know, we're going to do, do the mobility exercises a couple times a day, but the strength exercises just once a day is plenty. Like saying that to you guys, you would understand what I mean by that. But I've been challenging myself to not just presume that they're going to know the difference, or know what mobility is. Like they know the exercises and they know what they need to be doing, but you know, are they going to know that supine lumbar knee rocks are a mobility exercise? I'm not sure. So I'm really challenging myself to be more clear, and you know, either I'll write it in their notes from Physio app, or we'll talk through that specifically, so that I'm not giving the opportunity for that misinterpretation of something that could be ambiguous just because we have different baselines, I guess, like knowledge and skills.
Yeah.
It's like if, you know, I saw an accountant and they just talked to me about like, I don't know, finance words, like I wouldn't know. But they might be thinking, well, you know, this is common sense. Like everyone knows what tax is. Like, I don't even know how to explain it, but I think it
that's a good example
in a lot of scenarios.
Yeah,
That's a good example.
yeah, that's a really good way to put it.
And then as well, I think patient-generated metaphors can be really good opportunity to alter beliefs and expectations. So even if we're coming back to the way that they describe their pain or their symptoms, rather than you giving them a metaphor, if they give you something or a way of explaining it, you can use that to then talk about what's going on, but maybe adjust some unhelpful beliefs or expectations. And that's going to be in a way that's a lot more specific and, you know, going to be a lot easier for them to understand because they've already made that metaphor in their head.
Yeah. Do you have an example of that? I can't think of one.
Not yet in terms of like changing beliefs or expectations, but just sometimes when people describe their pain to me, if they use like a particular word that say I would have never thought to use to explain what's going on, I'll put that word in their notes, but in like quotations. So even like, I was asking someone, this is when I was a student on placement, but you know, okay, so you said, you know, what's the pain like when you turn your head to look whilst you're driving? And they said, well, it's not pain. It's just, it's a warning. It's a feeling of a warning. And yeah, maybe I don't really understand that and I can't relate, but that's their experience of what's going on. So I wrote in their notes, you know, neck rotation equals warning. Or some people might say, Ives, do you have any examples? I'm running short at the moment.
In terms of?
Probably the warning one's the one that stood out to me the most.
Yeah. That's
like it doesn't hurt, it's just a warning. Or they'll say, it doesn't hurt, it's just a feeling.
Yeah. That's
not really a metaphor, but it's, I guess, still aligning with that idea that everyone has their own way of experiencing things and feeling things.
I think you just nailed it just then. Everyone has their own different ways of experiencing different things, and that's okay. Yeah, you know, it's just really important to that's where it's hard when people, like what Rose said before, when they want that, and Riley used to that too, when they want that direction, but we want to involve them in the process. It's actually sometimes a very bit of a balancing act as well, because we certainly do want to give direction, but we want them to know that we want them to be a part of it, and that's an interesting concept.
I think there's like 2 slides to go. Are you guys happy to keep going?
Yeah, we can finish it off if you like. Yep.
so another little just one we can discuss. This was words to avoid and alternative suggested terms to use in musculoskeletal rehabilitation. Just have a quick read through that and then maybe give me a thumbs up once you've read through.
Hmm.
For context, I think this is interesting, and I'm not saying I agree with all of it.
Hmm.
Riley, what are your thoughts when you read that?
I think some are definitely beneficial. Like, just for instance, this is like not a very good example, but the lordosis and kyphosis one. When I first learned about that, I was like, oh my God, that seems so intense. Like, thought it was like this huge thing. And then they're like, yeah, it's just normal. Like everyone is born, like that's, everyone has it. Like, it's normal. And I was like, oh, like, it sounds like just some huge thing that's like not normal at all. And for people that don't have like any kind of like kinesthetic awareness and stuff, they would be like, oh my God, I have lordosis. Like, what even, everyone has that. You know what I mean?
Yeah.
Yeah. So I think some are definitely beneficial. I feel like you wouldn't really say to someone you're going to have to live with this anyway.
Mm.
So like obviously you just wouldn't say that. Like, you don't really need an alternative to it because you just, yeah. So yeah, I think some are good, but others like are just a bit
Much.
Yeah.
Rose, what do you reckon?
Yeah. Sorry.
Yeah, I think it just shows like how careful you have to be as a physio, because like someone could take bone on bone and run with it and be like, yeah, my bone's hitting my other bone.
Yeah.
You know, like I probably would, like someone.
I literally think that.
Yeah, like yeah, I think some of them, but then again, like some of them, like I probably would have heard you guys use the word instability.
Hmm.
Yeah.
Yeah,
Probably would
absolutely.
have heard you say
That
tear,
provides context.
damage. Like
Yeah.
some of them
Like, some of them can be said.
can
I
be,
think context is important.
yeah, definitely. Yeah, that's probably what I'm getting at. Yeah, but I agree, like with the lordosis, kyphosis, like it's like big scary words like that just people hang on to, as I said, and then it's a big deal. So
Well,
yep.
a funny story with the bone on bone one. So when the guy was talking through this, the example he gave was this woman was told that her pelvic floor had collapsed, or like, yeah, it had collapsed. And so she was like, well, of course, like physios can't help me. Like there was a floor, like there was a wall there
Oh,
and the floor, and it's collapsed, like it's gone. How is physio going to help me? Like I need surgery because this wall and floor collapsed.
Literally imagining that right now.
Oh
Yeah.
my God. But like, people would think like that.
Yeah, so it just is a good reminder that, like, again, back to that misinterpretation of ambiguous information, not everyone's going to know that pelvic floor or pelvic wall refers to a group of muscles rather than a physical, like, indestructible thing that's like fallen and broken and it needs surgical repair. And I just thought that was fascinating. Like, I would have never thought of that.
people stuff take things literally. So yeah,
Yeah.
that's
Guys,
crazy.
what do you think of this table?
I think this table is a little bit more ambiguous. I
Mm.
like that there's I like that there are definitely words you should avoid, but this is a little bit, I think this is a little bit more outdated.
Yeah, I think it's a bit too much.
This is just, yeah, this is
Only
too much.
2018.
You can say trap nerve, really? Like, all right, sure.
Yeah, some of it's a bit, again, it's a grain of salt. And that's
Disease condition, okay.
That's why I liked this presentation, because I like listening to things that challenge me,
Yeah.
because I feel like it actually makes me learn more. And
Yeah.
even the guy presenting, he wasn't saying like, this is exactly how, like, this is kosher, like, this is how it is. But yeah, I definitely think it's interesting.
That's good. But definitely what you said about the bone on bone thing, people will run with that, and it's so hard to change that perception. Like, it's so hard when people are like, yep, I got bone on bone, I'm done. I'm like, oh,
Like, people think that if they have osteoarthritis,
yeah.
their knees like click and stuff when they move, they think it's because the bones are physically grinding on each other. But like, they're told that, and they're told like all the cartilage is worn down and stuff. Like, they have every reason to believe that.
Yeah, that's the worst part. Like, you can't even blame them.
Mm.
It's
for
like
thinking
people
that.
who have like osteoarthritis, they're like, I can't walk because my bone's hitting my bone.
Yeah.
Like
And they're
that's
so usually set on it too. Like, you can't.
the thought process.
Yeah.
Yeah, strange. Anyway, yeah, that's my thoughts on it anyway.
This, we don't really spend long on this. So this is just
Yeah.
like more of the same,
Mhm.
considering how people might misinterpret medical terminology. Chronic, 2 steps from a wheelchair, instability liable to pop out, wear and tear, something is
Mm.
rotting away, neurological death within 6 months, could be a tumor. We don't need to go into it too much, but I think again, it's just demonstrating like we can't presume what these words mean to people. Even the other week when we were talking about, you know, when people say, oh, it's nerve pain, like that's what it feels like. Okay, but what is nerve pain to them? Is it just sharp pain? Is it pain that doesn't feel like a muscle? Like, we can't presume that we all have the same understanding of what nerve pain is.
I don't even know what nerve.
Yeah.
You'll learn.
Yeah.
You'll learn, don't worry. And that's an interesting one, because everyone says they have nerve pain, but they don't know what it is. And that's when it gets really fun for us.
Really fun. Yeah. And then the last one. Can you spot the 3 communication barriers? The wall is not one of them. Just shout out some suggestions.
The pen and paper.
So yeah, the clipboard being like right in front.
Mhm.
Um,
I'll let you guys talk.
The just body language, like sitting,
Mhm.
because they're standing. I don't know.
yeah, I don't know. She looks sad. I don't know if that's
Anything to add?
I don't know. I was going to say, I just don't know where his eyes are looking. It doesn't look like he's looking at her. So that's interesting.
Hmm.
Yeah.
I'm just going to pause this so
Yeah.
I can look at my answers. All right. So clipboard, no eye contact.
Yay.
White coat, uniform.
I was going to say that.
Oh,
White
yeah.
coat syndrome, but it can also work the other way around. So that's an interesting one. And then positioning, non-verbal sat directly opposite each other rather than maybe 45 degrees offset.
Hmm.
Mm.
So why the white coat? Sorry.
I think the idea, and it can go both ways, but the idea is that maybe by being in a white coat, you're seen as like higher than and like more official, and better than. But then the flip side of that is maybe like if we didn't wear uniforms, people might not think that we're as professional
Mm.
I would expect. It's like some physio practices, they have to wear polos, and like I've got friends that work in private practice, but they have to wear polos and dress pants and dress shoes
Yeah.
because of their client population. Whereas like I wear tights and runners, our patient population.
Are you saying that we should go into the dress phase,
No,
Jacinta?
absolutely not. I wouldn't come to work.
Oh,
Work from
geez.
Can you
home.
imagine?
It's so interesting.
I guess that's the concept of it can go both
yeah,
ways.
it can go both ways.
I would prefer to see a physio who wears tights and runners
Yeah.
rather than one that wears chinos and dress shoes, but that's my bias.
Yeah, I definitely see how people have preferences though.
Yeah,
Mm.
because when I worked at Bondi, when I was working in just renting a room, and they're like, no, you have to dress up to us. I'm like, oh, really? Like, sure. But in India, we had a meeting. It's so interesting. And when I was working in India, and we had a meeting talking about that, I think we should all start wearing white coats as physios. So it's so interesting. You should say that. And I know you're going to laugh, but culture is very different. And in India, people need to be told a little bit differently how, like, I wouldn't treat the same way in Australia as I would in India completely. So while I laughed it off at the time, and we certainly didn't do it, there was some thinking behind it. And I'll never forget, there was a clinic I went to, and that I thought they were trained podiatrists, but they were just physios. And the guy made them wear white coats. And I was like, wow, okay. And had a booming practice. So just something to keep in mind.
Yeah, I think it makes like a big difference what you wear too. Like I used to go to a physio where they wore like full like corporate suits, and it's just not personable. Like
yeah.
What like yeah. Like I feel so much more comfortable coming into our clinic than I would people sitting there with suit and ties.
And it'll attract a different clientele, of course.
Yeah.
You know, people who want a suit and tie will have a different expectation, and you know,
Yeah,
I've always
definitely.
talked about attracting your ideal clientele as well. So it's really interesting, but a really good slide to finish on, actually.
Yeah, that's the last one.
Yeah.
And that was just module 1.
Wow, can't wait. This is awesome.
So good, Jacinta.
Thank you so much, Jacinta.
really
That was just
Sorry it's a
fantastic.
bit long, but I just thought we had some good conversation.
Yeah, and that's just as we transition, we'll have a little bit of a break now. Of course, you can stop recording.
Yeah, let me stop.
We can press stop.